Hello, professor and class. Today I will be looking at the oxygen hemoglobin dissociation curve. Um, so if we take a look at the axes on the graph, the y-axis represents the percentage saturation of hemoglobin, which is calculated as the total amount of oxygen combined with the hemoglobin divided by the hemoglobin's maximum oxygen carrying capacity. The x-axis represents the partial pressure of oxygen, measured in millimeters of mercury. As the partial pressure of oxygen initially decreases from its peak, the y-axis remains relatively flat. However, as partial pressure continues to drop, the percentage saturation of hemoglobin goes down into a sigmoidal, kind of looks like an S-shaped curve. Okay, so where do we actually load and offload this oxygen? We typically load hemoglobin into the lungs, where the alveolar air has partial pressure of oxygen of around 103 to 104 millimeters of mercury. Under these normal physiological conditions, hemoglobin is around 98% saturated. This oxygen-rich blood then travels from the pulmonary capillaries to the arterial system, or systemic blood, and finally to our tissues. At rest, our tissues have a partial pressure of around 40 millimeters of mercury. At this pressure, the systemic venous blood hemoglobin saturation drops to about 75%, which means we normally unload about 23% of our oxygen to resting tissues. There can be shifts in this graph, however. This is where I'll introduce the Bohr and Haldane effects. So when the body experiences an increase in acidity, higher H plus ions, higher carbon dioxide, and an increased temperature, the curve shifts downward to the right. This rightward shift is known as the Bohr effect. Under these conditions, hemoglobin has a decreased affinity for oxygen, meaning that it lets go of oxygen more easily. This allows a lot more oxygen, around 38%, to be unloaded to the tissues at the same partial pressure. And conversely, the curve can shift to the left as well. This occurs when hemoglobin has a high affinity for oxygen, known as the Haldane effect. This leftward shift occurs when there's low CO2, low presence of protons, a low 2 to 3 BPG, and a lower temperature. In this situation, hemoglobin holds on just tighter to the oxygen, and only 13% of oxygen is unloaded. Now we'll be talking about chronic obstructive pulmonary disease. So, in this disease, airflow limitation and damaged alveoli severely impair oxygen diffusion, resulting in a decreased overall oxygen saturation. A patient would usually present with shortness of breath, confusion, and rapid breathing. To restore oxygen saturation, strategies usually consist of supplemental oxygen via nasal cannula or a mask to increase the concentration of inhaled oxygen. For severe breathing difficulty or respiratory failure, mechanical ventilation can be used, and medical management is also used as well, like utilizing bronchodilators to open airways or steroids to reduce inflammation. And for the final question, does oxygen saturation decline during a graded exercise test? The answer would be yes, it declines significantly, just because vigorous physical activity increases the metabolic rate of tissues, which in turn increases metabolic heat, the acidity in the active tissues. This releases more CO2 and more H plus ions, which just triggers the Bohr effect as we discussed earlier, which just causes more oxygen to be taken in by the tissues because they're working harder. And yeah, thanks for watching.